Thank you very much for having me today. So I am going to be speaking about data at another level of analysis, kind of beyond imaging and cortisol, more at the neurocognitive level. Last year I actually presented the imaging results from this study at the same meeting, and I'll try to talk a little bit about the correspondence between these neurocognitive findings and our imaging findings. Okay, so many people might be wondering, why should we be measuring neurocognitive function in psychotherapy trials? And as some of the previous speakers already highlighted, we tend not to see imaging or neurocognitive measures incorporated into these psychotherapy trials. When they are incorporated into treatment trials for people with mental disorders, it tends to be pharmacologic treatments, and often in patients with psychotic disorders. But there might be a good reason to examine these measures in psychotherapy trials for BPD. And I think that maybe one of the reasons that these measures haven't been used in these trials is because we don't often associate cognitive deficit to people with BPD, or we think that maybe cognition is disrupted more when people with BPD are experiencing some kind of emotional state. But deficits on these performance-based cognitive measures or changes on these measures through treatment may provide unique information about clinical outcomes that go beyond self-report symptom measures. So I want to highlight here a meta-analysis I completed when I was a graduate student, which essentially shows that there may be a range of cognitive functions that are affected in BPD, especially executive functions, including things like planning. As you can see here, these are deficits across various studies on neuropsychological functioning in BPD. And impulse control is one example of a cognitive function that may also be reduced in people with BPD. And so some people might also be thinking, well, are our patients actually trying on testing? Sometimes the stigma associated with BPD is that they may not be trying on our testing. But in fact, in this research that I recently published, looking at least 50 outpatients with BPD, and we use a performance-based measure of validity on cognitive testing, that most people, the vast majority of people, are trying on our cognitive testing, and the very small number of people that may not be trying on our testing, or I shouldn't say trying, but putting forth an effort on testing, they may be performing worse actually on the more effortful tests of things like response inhibition or impulse control. So I use all this to say that I think we can trust cognitive testing and maybe incorporate these types of tests into our treatment trials. So the aims of this study, similar to the presentation I made last year, are to determine whether pretreatment performance behavioral indices of response inhibition, which is our proxy of impulse control, predict frequency of self-harming behaviors after DBT. We intended to test people after 6 months of DBT. As it turned out, it ended up being more like 7 months after treatment. So that is the reason that you'll see 7 months throughout the slides. And we were also interested in assessing the association between changes in these performance-based measures of cognition and changes in self-harming behaviors through treatment. This study was funded by the American Foundation for Suicide Prevention and incorporated both imaging and cognition. And so this is the reason that we're especially interested in self-harm. Okay, so I won't go through all of the details, but similar to previous presenters, we had at least a certain number of instances of self-harm that were necessary in the past year to be included in the study. Treatment took place in Shelley McMain's clinic at the Center for Addiction and Mental Health in Toronto. There were several exclusion criteria related to DBT treatment in the past, but also to ensure that these people were clinically stable and also neurologically healthy. And because people with, for example, severe head trauma or other central nervous system dysfunctions, this might affect their cognitive functioning and also potentially their ability to engage in and participate in psychotherapy. Also, we required that participants provided a negative drug screen prior to testing, so none of these findings could be influenced by at least illicit drugs, but we didn't have any requirements regarding medication, so some of these people were currently medicated. So our measure of response inhibition and attention, I'll be speaking a little bit about attention as well, was the Conners Continuous Performance Test, or the CPT. We now have a third edition of it, but when this study was completed, we used the second edition. And it's a computerized measure of visual attention and response inhibition. There's actually been a study showing, for example, that the measure of visual attention on the CPT may be impacted as a result of the mindfulness training through DBT. So there's reason to think that this measure might actually be impacted through this type of an intervention. Now, this test presents examinees with a black computer screen, and what happens is they see letters pop up on the screen. People who have done this probably don't like it very much, but what happens is they need to press the space bar every time they see any letter pop up on the screen. So A, B, C, D, they have to keep pressing that button, but when the letter X pops up, they need to withhold their response, not press the space bar. And so this test goes on for over 10 minutes. It can be quite frustrating, especially for people with BPD. But what we find is that it is quite sensitive to their ability to sustain attention, be vigilant, and also to inhibit their behavior when appropriate. And all of our participants put forth adequate effort on testing. So when we look at our indices of response inhibition, this test uses two different measures. One is something called commissions, which is essentially committing an error, where they provide a response, a button press when they're not supposed to non-targets, which are the X's. And in some research that we published a few years ago, for example, you can see that this type of a paradigm, except to use a go-no-go task, activates the prefrontal cortex quite robustly. And in the research that I presented last year, we also showed that that people with BPD who go through this treatment show less activation prior to beginning DBT compared to a control condition, and then after treatment show increases in these areas of activation that you see in the prefrontal cortex after treatment. So I'll talk a little bit more about, again, the correspondence between the imaging and the behavioral findings later. And then perseverations. They don't end up being very relevant in this study, but one other way that this task measures impulsivity is if somebody provides a response that's so fast that it would have been physiologically impossible for them to have actually processed that stimulus and provided a response. So it's almost kind of like this very automatic disinhibition of the motor response. Okay. So we won't go through all of these things, but I want to show you that we did have a pretty comprehensive screening process. 63 people were screened for eligibility. As it turns out, 31 actually completed the time 1 lab assessments. And then in terms of people that we could actually compare between time 1 and time 2, were 18 patients with BPD who went through treatment, and people were kind of taken out of this for various reasons, including positive drug screens at various points through the protocol. Okay, so in terms of the participant characteristics, at least in the time 1 assessments, we had 31 patients with BPD, primarily women who are right-handed, almost 29 years of age on average, almost 2 years of post-secondary education. They were of average IQ, primarily white. And nearly all of them did have a history of psychiatric treatment. Less frequent was inpatient hospitalization, but outpatient consultation or treatment did occur. There were several people who were on medications. Sample size is too small to really examine in a systematic way how this might have influenced the results, but I wanted to mention this to you all. Okay. In terms of the frequencies of different types of self-harm, we're speaking here primarily about people who were engaging in cutting, hitting, but there are also other forms of self-harm, overdosing, hanging, and other things that didn't neatly fall within this parasuicide count measure. So in terms of clinical symptoms, how did these change after 7 months of DBT? Well, We looked at depression symptoms using the MADRS, the YMRS for mania symptoms. You can see that there were moderate symptoms of depression across the sample. These minimally were reduced after 7 months of treatment. Mania was quite minimal as well, and you didn't see very many changes in that. In terms of self-reported impulsiveness using the Barrett Impulsiveness Scale, what we found was that attentional and motor impulsiveness was significantly reduced after 7 months of treatment, but not planning impulsiveness. And that despite these significant reductions in self-reported impulsivity, we don't see any associations between these reported behaviors of impulsivity and any self-harming behaviors, actually. All right, so in terms of proportion of people who were reporting self-harm, we focused on certain forms of self-harm as well as cumulative self-harm based on how many people reported these types of self-harm. The main types of self-harm, and you can see that they were reduced in terms of the number of patients that continued to report them. It was cutting and hitting that was significantly reduced in terms of proportion of patients, but we also saw overdosing and burning and other things that were quite prevalent. Cumulatively, self-harm was significantly reduced, or I should say, after 7 months of treatment, especially burning, hitting, and other forms of self-harm. What we found, interestingly, was 2 people that began to increase their rates of self-harm, of cutting specifically. So that looks increased, but it's not significant, and it's due to 2 people who are outliers. Okay, in terms of pre-treatment cognitive function and how does that predict self-harm frequency at the 7-month assessment, what we found was that poorer response inhibition, so lower scores on the commissions index was, prior to beginning treatment, was correlated with a lower frequency of self-harm after 7 months of treatment, specifically relating to these ones where enough people were reporting them, other forms of self-harm as well as overdosing. And this is quite in line with our imaging findings as well, where we found that lower levels of activation on a response inhibition task using imaging were correlated with subsequent improvements in self-harm. So there tends to be this story that is coming out of this data, at least, where lower levels of brain activation, but also lower levels of functioning on performance-based measures tend to be associated with later improvements in these behaviors. And a small comment on sustained attention, which we know improves through mindfulness, that poorer sustained attention before treatment was correlated with a lower frequency of cutting after 7 months of treatment. So again, still the same story, that lower performance on these cognitive measures before treatment is associated with better functioning later. Okay, what about changes in response inhibition? This figure here, the green line should be at a 50. That's a T-score. So the average is actually a 50. And what I just want to show you here is the red line. So this is kind of a plot of the different indices of the CPT. The red line is people with BPD prior to beginning treatment, and higher scores reflect worse functioning on this measure. The yellow line represents people who completed 7 months of treatment. Now, none of these are statistically significant. We're only talking about 18 people here. But what you can kind of see, I don't know if these are practice effects, but what we're seeing, at least in terms of response inhibition on commissions, is that there seems to be a slight reduction in response inhibition deficits after 7 months of treatment, and overall this kind of slow decline in the other measures, mainly looking at attention. So some indication that maybe treatment is affecting performance-based measures of cognition. And if we look at associations between changes in self-harm and neurocognitive functioning, what we found was that worsening response inhibition over the course of 7 months of DBT that was actually associated with an increased frequency of cumulative self-harm over 7 months. So otherwise, we didn't see any other associations between changes in specific types of self-harm. It was really at this cumulative level. All right, so what does all this mean? So there are, it seems like greater response inhibition deficits prior to beginning DBT may prospectively predict improvements in self-harm. So those with the greatest deficit may benefit the most from a treatment focused on improving self-regulation. And that's consistent, as I said, with our recent DBT neuroimaging findings. That was a completely different task that was used with imaging. So this is, quite interesting that we're seeing these things across two different tasks. Declining response inhibition, interestingly, might actually connote a resistance of self-harming behaviors to treatment with DBT, at least within the 7-month time frame. And another final finding that I want to comment on is that there were no associations between self-reported impulsiveness and frequency of self-harm or changes through treatment, suggesting that maybe it's these performance-based measures of impulse control that are telling us something more about treatment response for self-harm and could represent what we sometimes call an intermediate phenotype for self-harming behaviors in BPD. So, I'll say really quickly that we're doing other studies to follow up on impulsivity and its risk for self-harm and suicide attempts in BPD and other groups. And I would like to especially acknowledge Shelley McMain and others in Toronto and Paul Links for supporting this research, as well as the funding sources listed here. Thank you. Went a little over.